It is kind of like a rehab unit, except they may not necessarily do rehab. It just means that there's some, do what?
Forget.
Bring it in your ears, is that
Yeah.
better? Is that better? Just don't stand there. Okay. Just don't have me stand there. If I get close there, because I didn't hear it. I can try to hear whistling a little bit, but I didn't hear it higher. Better? And what a skilled nursing unit is, it means that the patient needs some sort of RN skilled care. It could just be nothing more than frequent dressing changes, but they need something that requires an RN to do. And so they're on this unit for that period of time. So it's pretty much like a rehab type unit, although it may not be physical therapy that they need. So this patient has a history of multiple sclerosis. That is her problem. And she came into the hospital. This skilled nursing unit is within an acute care facility. And she came into the hospital to have a laparoscopic cholecystectomy. At the time that a laparoscopy was done on this woman, she would have probably stayed overnight and maybe one more day. And so when she had that done, she really wasn't progressing as quickly as she should, so they put her on the skilled nursing unit. And you can see she's been there 3 weeks now. She's been since 3 weeks that she had a lap COVID. Most of her problems, they think, are just due to decreased mobility, and that's related to her multiple sclerosis. She does have 3 physicians caring for her. She has a neurologist as her admitting physician that's been seeing her for years with her multiple sclerosis. She has a general surgeon who performed the cholecystectomy, so that's the person who did the surgery. And then a psychiatrist who treats her for depression who has also been seeing her for years. So she has a long-term history with the neurologist and the psychiatrist. She's complaining of severe nausea on this shift. This is what's the new thing that has happened. Her puncture wounds with the lap chole are dry, well-approximated, scar tissues forming. In other words, they're healed. They are healed. She's been there 3 weeks, so they've had time to heal. She has generalized muscle weakness that's normal for her. Nothing new as far as her muscle weakness is concerned. She normally uses a wheelchair for mobility. She is also complaining of a frontal headache that is dull in nature. These are her vital signs. Any of those vital signs concerning to you? Her respirations are a little concerning. She has Phenergan prescribed for nausea, and she last took it a week ago, so she really hasn't been having much problems with nausea. Since her lap chole and is healing from that, she's not had really any problems. So let's talk about what other questions do you have and what assessment data do you need on this one? This was your patient, and you walked into her room. You're working the day shift today. You walked in her room and you got the information that I just gave you. Is there any other assessment data that you need? Has she eaten or drinking anything before she got sick to her stomach, and she has not? You want a list of her medications? Okay, we'll get that. Is she having any difficulty voiding or having bowel movements? If they had asked her that, which they did not, she probably would have said that she was not having any difficulty urinating. What we don't know, and what a very nice piece of information was, when was her last bowel movement. We don't know that. Anything else? Describe her pain in further detail. So she's told us it's a level 4, right? Did you see that on her vital sign? She's told us a level 4. It's in the front of her headache, front of her head, and it is dull. Is there anything else about that pain you want to know? Yes, when has it started? Has it happened before? Those would be interesting things to know. And most likely, had they asked her that, she would have said it started when she woke up. She's not going to wait long when you make this round. So she woke up with it. She does have a history of migraines.
Is there anything that triggers the migraines?
If there is, we don't know it. Anything else that you want to know on her? Let's go back and look at her data that you do know. You would listen to her bowel sounds, you'd want her O2 sat.
What happened last time she
What happened the last time she took the Finnergan? I'm sorry? We'll get her medicine list. It'll come. We'll get that. Anything else? All right, so that's the history. What type of physical exam would you do on her? Neuro? You would do neuro? And what does that mean when you tell me you're going to do neuro? So if you had to pick two priority body systems, given the information you have, would the first one be neurological? How many of the first one's going to be neurological? Raise your hand. How many, so what's the second one that you want to do? How many is GI the first system you're going to assess? Why? Because the change is nausea, right? The change is nausea. So that's where we need to focus. She has a long history of multiple sclerosis, a long history of that. So we don't have any indication at this point that that's what's changed. So GI would be our preference as far as if we're going to assess this woman, as if we could only do one body system, we would focus on the GI system. In fact, her surgery was GI, wasn't it? But it's the change that's prompted it. She's been here 3 weeks, long enough that her surgical site is essentially healed. She's been here so long that her surgical site is essentially healed. She does have multiple sclerosis, but she's had that for a while, many years, to the point that she's been wheelchair mobile with it. And so there's no indication it's the multiple sclerosis that's causing her current problem. And the only change that we have is this nausea and the headache. Now then, what about that? What about the headache? What system would you assess for that? Does headaches ever cause nausea? So you're going to have to link those two together somehow. You're going to have to look to see, is this a GI problem, or is this associated with her headache, which is more of a neurological problem. So when we say we're going to do a neurological assessment, we specifically mean we're going to look at this headache. We're going to do a complete pain assessment, as well as looking at changes that perhaps this headache could be causing with her. Those would be our priorities. Okay, a lot of this data I can give you, but there was a lot of data that was never collected. So if it was never collected, I don't have it to give you. I did put the Muse up here, so let's look at that. Her heart rate is 82. Does she get any points for that? No. Her blood pressure systolic is 138. No. Her respiration is 24. Does she get any points for that? 1. She gets 1 point. Her urine output in the last 4 hours, nobody collected it. We don't have any indication it was a problem at all. It's matter of fact, throughout the entire case, there's not really any indication that the urine output is a problem. Her central nervous system, she's awake and responsive, so she doesn't get any for that. We didn't do an oxygen saturation. This time when this case happened wouldn't have been something they did on a routine basis on a skilled nursing unit. Most likely it would be fine. Probably would not have gotten any points for it. And she's not requiring any respiratory support. So right now she has a score of 1. Okay, the patient has promethazine, which is Phenergan, IM prescribed Q6 to 8 hours PRN. It was administered last a week prior. It is prepared in a vial labeled promethazine 50 milligrams per mil. The patient is 65 inches tall and weighs 122 pounds. Would you administer this for the nausea she is experiencing? How are you making that decision? You what? PO Challenger? Okay. Christine was going to PO Challenger. Give her some water, see what happens. Anybody else? What are y'all doing? You've been taking care of patients in the hospital. Have any of them told you they're nauseated? What did you do? You what? You gave them the Phenergan? Or Zofran, whatever was ordered. You gave it to them? So why are you hesitating with this one?
We don't know if it's triggered by the headache.
It's ordered item. Well, it's ordered item. So if you wanted to change it, what would you have to do? You'd have to call the doctor and get it changed, wouldn't you? Now, she has been taking it that way, this hospitalization. Anything else that's going through your mind? So if you were in the hospital and you saw this, and you saw this order, would you have said, I don't want to give it IM and call the doctor? No? What would you have done? Would you have given it? I just want to know what y'all would do. Just tell me, as you're taking care of this patient, what would you really do? Okay, so if she can't swallow without vomiting, they're not going to give you a PO because she has to swallow the PO. You could call and get an IV. She does not have an IV, but you can put one in. So the problem that you're having is you don't like the drug. Is that the problem? You don't like the drug? That's not your problem, eh?
I don't have a problem with it.
You're giving it?
Yeah.
Okay. I like somebody to make a decision. Christine's made a decision. She's going to challenge her PO. May's made a decision. She's giving the Phenergan IM. Anybody else going to make a decision? Y'all just going to sit here and look at this patient like this?
Did it work last time she took it?
If it's a migraine, the Phenergan helps. If it is a migraine, she's going to tell you the Phenergan does help. It doesn't relieve all the pain. She usually has to take something else with it, but it will help if it is a migraine, which is not unusual. Not unusual. And you know, Phenergan helps. It doesn't help people. It does help a lot of people with migraines.
Do we know if she's constipated?
No, we don't know.
Because that's a complication of Phenergan.
Sure, it's a complication of all the pain medication too. So when your patient's got a pain level of, let's say an 8, do you say I'm not giving them the narcotic because they're constipated? No. I want some decisions here. Are you giving the Phenergan IM? How many of you are going to give it as it's ordered? How many of you are going to call the doctor and change it to another route? Nobody? How many of you are just not going to give it? How many of you didn't vote? Because there's some of you that did not vote. Those are people who are not making decisions. There's a reason this class is called clinical decision making. We have to make these decisions, don't we? This has happened. This is a real patient. This really happened. At this particular time when this case happened, Phenergan would have most likely been the drug ordered. Granted, it may not have been ordered IM. That's not a typical way, not terribly unusual, but not the most typical way. I would have expected it to be ordered IV. But as somebody said, she doesn't have an IV, so that's maybe why they put it. I ordered it IM. And I do know Zofran is given more often, but it doesn't work as well, does it? This woman has a history of migraines, so Phenergan is probably her drug of choice in this situation. All right, so if we're going to give an IM, what volume of medication would we administer? 1.1? 0.5. We're going to give 0.5 what? Milliliters. We're going to give 0.5 milliliters. All right, so let's just start with the syringe. Which syringe are you going to select out of the options that you have in a hospital? Which syringe are you going to select? I just want the syringe, not the needle. 3 milliliter? A 3 milliliter, okay. And then once you selected that 3 milliliter syringe, what needle will you select to administer it? I don't care what needle you use to withdraw it, but what needle will you select to administer this medication? A 22 gauge 1 inch? Everybody going with a 22 gauge 1 inch? 1.5 inch gauge lights, 1.5. So we've got 2 to go with. How many are going with a 22 gauge 1 inch? How many are going with a 22 gauge 1.5 inch? There's lots of you who haven't voted, so what does that mean? You don't like the 22 gauge? How many of you don't like the 22 gauge? That part bothers you. But it's not bothering anybody, Christine. It's not bothering a soul back here. You can't see them behind you. They're just not voting. So the majority of you like the 22 gauge 1.5 inch. That was the best pick. Why? What's the difference between a 22 gauge 1 inch and a 22 gauge 1.5 inch?
How deep
Don't
it
tell me
goes.
to lead. Everybody knows it's a lead. I mean in response to why you're using it.
I am, so it goes in deeper into the muscle.
You got to get this drug to the muscle. You have got to get this drug to the muscle. If you give it too shallowly, it will cause an abscess that can cause investigation so that the tissues become ischemic and necrotic. This is not a drug you can inject too shallow. If you do, you can make huge problems for this patient. So if you're going to make a mistake, go too deep on this one. Don't go too shallow. She is 65 inches tall. That is how tall? 5'1". 5'5", and she weighs 122 pounds. So she's probably substantial enough that you could do a 1.5 inch needle. Anybody in here weigh 122 pounds and be about this tall or way close to that? Anybody willing to say they do? You are, aren't you? Stand up. Here's somebody. I would do it myself. She's 5'4", so she's an inch shorter, but you weigh about that much. And so, yeah, we could use a 1.5 inch needle on her, couldn't we? On one of our Britneys here. No. Yeah. So it'd be appropriate to do. Who would use a 1 inch on? Which IM? If we're going to give an IM, who do we use a 1 inch on? Where? Is it the location? Pediatrics, children. Yeah, children. It's not the location. If we're going to give deltoid, we might do a 1 inch. We might even do something shorter than that. But we would never give Phenergan deltoid. No. I mean, there's some people we could. It wouldn't cause any harm. You know, they got nice muscles here, maybe like Arnold. He's got nice muscles, right? We can give him maybe in the arm. Most of the time we're not, because that muscle is not as well developed unless you're lifting weights and that sort of thing. So we're not. So which injection site are we going to use? The ventral gluteal. We're going to use the ventral gluteal, so now we need to be able to find the ventral gluteal. We need to be able to find the ventral gluteal in order to do this safely. Okay. Very good. They did not give her the Phenergan. Once you administered this medication, they didn't even address it. I mean, it wasn't like it was a decision. It was one of these that didn't vote. Once you administer this medication, When would you return to assess if the medication had been effective in reducing her nausea? And why do you say that time?
30 minutes.
30 minutes? How long? 20? And why are you using that time? That's pretty specific. Why that time?
That's what the drug book says.
It says reassess in 20 minutes. Does it say literally that?
No, it says onset.
Onset 20 minutes. Thank you. That was painful, but that's exactly. So if we were in the emergency department, we would go with onset. We're on a skilled nursing facility. We would most likely use which time frame? Peak. It makes a difference. And in an inpatient setting, we would probably look at peak. So what's the peak time?
20.
About 20, 30 minutes, same thing?
It says unknown.
No, yeah. So in that case, we'd have to use the onset because we wouldn't have anything else, would we? So we'd come in after 20 minutes and see if this is working. If you're in an emergency situation, you are going to look at effectiveness at onset because you're trying to get them out there quickly, right? But in an inpatient setting, we're going to look at peak, and that's because we want to know the most effect. We want to know what is having the most impact on that patient. Good, that's very good. I like that. And what common adverse effects would you monitor for? Drowsiness. Number one, drowsiness. Vinegar makes you sleepy. Makes you sleepy. Anything else that it does negatively? It decreases respiratory drive, but just slightly, unless you get really sleepy. One of the things it can cause, all the phenothiazines can do this, is it can cause some paranoia and anxiety. That whole something bad's about to happen to me feeling. Can make, I've seen people in the ER feel like they just have to leave, they have to escape based on the phenothiazines. Sometimes why the ER doctors like them. People want to get out of it. All right, so throughout the shift, as we go along, the client states she is vomiting small amounts. She was asked to save her emesis for the nurse to see, but she doesn't do it. Her fluid intake was 450 mils for the last 4 hours, and her urine output was 550 mils. So is that good or bad output? What's 550 divided by 4?
137.
137, so well over 30 mils per hour, right? So her psychiatrist makes rounds, and he states he believes her nausea is related to a fear of going home. It's about time for her to go home, and not a physical ailment. Shortly after the psychiatrist leaves, the client states her headache is worse, now a pain level of 6. Remember, they've not given her anything at all. And she is more nauseated. She requests coffee and asks if she can go outside to smoke. Got the picture? What would you say to her? No, why not? You're not allowed to smoke on campus? I can promise you that request will lose you 2 points on a test. If you say to a patient who says, can I go out and smoke? It's against hospital policy to do so. I can promise that's the wrong answer. Promise that's not. What's going to be a better answer? There's only one right answer. Are you willing to quit? Bing, 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 you got it. Are you willing to quit? That's the only right answer. Because once she's disclosed this, you are responsible for initiating smoking cessation. You are responsible for that. That is a Joint Commission requirement. Once she says, I want to smoke, you are responsible for that. If you're not doing it, then you are shirking your responsibility. That's a Joint Commission requirement. So, saying, are you willing to quit? Now, why do you start with, are you willing to quit?
You can't
If they are willing to quit, you have a teammate in the process of assisting with quitting. You have a team member. If they're not willing to quit, you have an opponent. You're going to deal with an opponent different than you're going to deal with a team member. And so you need to know up front which one you're dealing with. Now, when we do say we're not willing to quit, they say to us, no, I can't quit now. I'm too stressed at this time. And that's most likely what she would have said, right? This is no time for me to be quitting smoking. Then what do you do with that? I'm sorry? What do you do with it? Educate her about what?
Like the risk and benefits behind stopping opposed to continuing to smoke.
Okay, so your second response, you ask her if she's willing to quit. She says, no, it's just too stressful right now. I'm in the hospital, I've got a lot going on, the doctor sent me home, I'm scared about that, it's too stressful. Your response is to tell her what the risk and benefits of smoking. Does that make any sense? One, does she know the risk and benefits of smoking?
Yes.
Can you live in the United States and not know the risk of smoking? Can you possibly live here and not know the risk? I'm sorry? They claim they don't know there's any risk of smoking? No, they all know the risk. They know the risk of smoking. That's not the issue. What is it that they don't know? They know the risk. They know it could lead to lung cancer. They know that it's very detrimental to their health. They know that. What is it they don't know? How do they stop? That's what they don't know. So if you're going to educate them, you're going to educate them on how to be successful in stopping smoking, not the risk of continuing to smoke. Even children know that. That's the risk of smoking. You might educate this particular person about the risk associated with her MS. Maybe she doesn't know that, but you don't know it either, so it's going to be hard to educate it. Because you got to go in and think about what happens with smoking and how that affects her neurological system, right? That's what the MS is about. So you've got it. You can educate that. This is what I mean by when you have an opponent. She has said, I'm not going to quit smoking because there's too much anxiety. Your next response should be, let me tell you how to relieve that anxiety so you can quit smoking. So you can quit smoking. Let's find some interventions to help you reduce that anxiety and not need those cigarettes as much. That would be the correct answer. Not, well, let me tell you how dangerous this is. That's not going to help anything. So, steps of an evidence-based smoking cessation program. You've got to ask if she's willing to quit smoking with assistance and establish a quit date. You give them the hazards of smoking, but that means the hazards specific to whatever condition she has that perhaps is not so well educated across the national globe. You're not going to tell her about her risk of lung cancer. You're going to tell her what changes are happening in her neurological system. She may already know that. She may already know that because she may have already received that education. So one of the things we can start out with is learning what she already knows about the hazards of smoking, the benefits of quitting. Some people do not realize that if they quit, they can recover some health that they have lost because of smoking. Maybe not all of it, but they can recover some of it. And we need to think about, for many patients, probably not this one, but for many patients, managing weight is an issue with quitting smoking. Even if they've never been heavy, they've heard that once they quit smoking, they'll gain weight. My mother was a long-time smoker. She never, I think, ever weighed more than 105 pounds her entire life. And she quit smoking several times. But one of the things that always bothered her when she quit smoking was she gained a little bit of weight. She was always so tiny, tiny, tiny her whole life. So that's a big issue for some people. So we need to look at that. We need to look at psychological and emotional support, like counseling, support groups, sponsors, that sort of thing, and pharmacological support. So we can use things like over-the-counter nicotine replacements, they call the NRTs, prescription nicotine replacements, and then prescription medications. As we look at these, she may have some contraindications that we can't use. In particular, things like Wellbutrin may not be the best drug for her because she's on antidepressants. We don't know which ones right now, but we know that she probably is. So we have to look at those types of things. We could also manage her anxiety with a benzodiazepine. Benzodiazepines are the drug of choice for withdrawal. So if you're looking at withdrawing from some sort of addictive substance such as nicotine, benzodiazepines are really effective for that. She tells you that she thinks her headache is a migraine. She has a history of them, and that nicotine and caffeine had relieved her migraines in the past, or assisted in relieving her migraines in the past. Do you believe that's true? Yes. Why? It vasoconstricts, does it? That nicotine and that caffeine can cause some vasoconstriction. So if her headache is due to vasodilation, a little caffeine, a little nicotine might relieve it. So we can't give her the nicotine unless we give it to her in a patch form. We could call and get the patch form, but we could certainly give her some coffee as long as she's not in PO, and she's not. She's not in PO at this point because nobody's paying attention. At this point, nobody's paying attention that she's even had a change in condition. The patient requests the nurse call the physician to report her symptoms. Are you going to call? And when you do, what are you going to tell that doctor?
Smoking, she hasn't had a cigarette for so many hours, she would like to have a cigarette, and then give her some sort of.
So you're going to ask for an NRT, okay? Anything else? How about all the other symptoms she's had? What about the nausea? What about the fact that she's been saying she's vomiting? Are you going to tell him that? Which physician would you call? Which one? The neurologist. Why? It's too far past her surgery. You'll think this is surgery related, so therefore you're going to go with her admitting physician. Hospital policy requires the ISR as its nurse to physician communication technique. This means you must identify yourself and your patient by two identifiers. You again give the report using the SBAR technique and end with a readback of the information received. So I want you to write down on a piece of paper, pull out a piece of paper, put your name at the top. Today is April 4th. You did know you were responsible for bringing paper for most of your friends, is that right? Did they let you in to know that? Arnold's too cool with their paper. I put your name at the top and it's 4/4/16 today. I want you to write out your SBAR report. You should write it out. You want me to flip back to, how far back do you want to go? There, you want to go back further?
The name is ordered,
What's her name?
You don't have to put out a name. I don't think we even have a name, just make up a name, it doesn't matter. You know, their vital signs in here, let's find what those are. There's her vital signs. You don't have to do the I part, just the S part. Just the S part. I'm sorry? 6. Have you seen the nurses use SBAR in practice? If not, you will. Wichita Falls is always so slow to adopt things. All right, do we have an SBAR report yet? Let's turn it in that direction. The end of the hall, the end of the road, that direction. Can I do what?
Let's go forward.
Pass it in down here.
to the house.
If you've got any more, come up here and bring them. Okay. Do I have them all? Now do I have everybody's? Jordan's coming up here. Do I have everybody's? Okay, let's go forward. All right, the neurologist asked the nurse to consult with the general surgeon. The surgeon visits with the client and prescribes a survey agent, CBC. He also prescribes metoclopramide, which is what type of drug? GI drug. What does it do? It improves gastric emptying, that's right. 10 milligrams IV post Q8 hours. He writes in his progress note that the client is experiencing hysteria over the possibility of going home. He also writes she's experiencing nausea and hypoactive bowel sounds in all 4 quadrants. So do you like this drug better than the Phenergan?
Yes.
Yes. This is a better order. They did not call the doctor, so this doctor just made rounds. So far we've only seen the one doctor, right? The psychiatrist, now the general surgeon comes in. So he notes a change. She has hypoactive bowel sounds. We just talked about that. It's being given to increase gastric emptying. After 2 hours, the pharmacy's not sent the drug. The nurses fax the order and call them twice, but the drug never arrives. What action would you take? Send somebody to go get the drug? Good, that's a good one. Had it arrived, it would have been available as this. How many milliliters would you administer? 2 milliliters? Would you dilute it? And you can see what the next question is what rate would you inject it? It's IV, yeah, 2 milligrams IV. Okay, 10 milligrams IV push Q8 hours. So, are we diluting it? Yes? How much are you putting in to dilute it? 2 milliliters? So you're going to pull out 2 milliliters and put 2 more milliliters in, so you have a total of 4 milliliters? Is that what you're telling me? How are you deciding this? How are you deciding if you need to dilute it or not? A drug book? Which drug book are you looking it up in? I'm sorry? You're looking it up, you're not looking it up in Lockhart. You're not looking it up at all. If it's only 10 milligrams administered over 1 to 2 minutes, you can give it undiluted. The Gayheart book will say the exact same thing. If it's more than 10 milligrams, you've got to dilute it. But up to 10 milligrams, you can give it undiluted. You've got to give it over 1 to 2 minutes. The neurologist makes around 2 hours after the surgery. He writes in the progress note that the client is emotional about going home. He states she's possibly gagging herself to delay discharge. He does not prescribe any new treatments, but states the client may not go outside and smoke. She becomes very upset over this and requests a tranquilizer to help calm her nerves. She has prescribed Xanax, 0.5 milligrams POTID, PRN for anxiety, and she's not taken any today. Are you giving it to her? That's the next question. What do you know about this woman at this point? She's anxious, she has a headache, she has a history of migraines that might explain the headache. We've not allowed her to go outside to smoke, which is one of the things she does to help relieve her headache. What else do we know about her? She's got a nicotine patch ordered. What else do we know about her? I don't know how I said that when she's anxious. What else do we know about her? We don't know why. She has a history of depression. What else do we know about her? I want y'all to know that the majority of you would make the exact same mistakes the nurses that took care of this patient made, because you're not looking at the most important things that have happened in this case. You know that she has been complaining of nausea, that she states she's been vomiting on and off all day, but she's not shown the emesis, has she? She has not shown you all that. You know she has low hypoactive bowel sounds because the surgeon documented that. Would you administer the Xanax? She's drinking fluids. Well, no. It's PO. What are you going to do? Her psychiatrist talked to her. Yeah, he talked to her. Asked her why she wouldn't go home, want to go home. She's just afraid. You know, she's just afraid that she'll get worse, that's all. So you're giving this, but if you're not giving it, what are you doing for her anxiety? Imagine if I turned this into an exam. I could have easily done that. I could have easily, instead of showing you this case, turned these questions into exam questions. I could have given you these scenarios and said this patient has this problem, would you give this Xanax? Or would you do this, or would you do that? So you might want to figure out whether you're going to give this or not. And if you're not going to give it, what are you going to do? I'm waiting for an answer. How many of you are giving this Xanax? Give her with the snack. How many of you are not giving her the Xanax or made the decision not to? Okay? Of those of you who made the decision not to, what are you going to do? You just wanted a different form. So you call the doctor and get the benzodiazepine ordered in, let's say IV form. We gotta have the IV for the regular anyway, right? So that's a good, I like that option. We can call, you can give it to her, or you can call and get it into a different form. Either option would be correct, but not giving it is not appropriate. Because what you've done is you've identified your patient's anxious. She has a prescribed drug for anxiety and you've not given it. You've not given it. You've said, no, you're not anxious enough to take your prescribed drug. Here is the results of the lab ordered by the surgeon. So is anything abnormal in these labs? So what's abnormal? Not the sodium and not the potassium, but the chloride's a little low, isn't it? And the CO2 is a little high, which tells us what? Metabolic alkalosis. Okay, so now we got to decide what causes metabolic alkalosis, right? Then we look at the BUN and creatinine. The BUN is elevated, but the creatinine's normal. Dehydration makes sense. She's not drinking a whole lot of fluids, is she? Her glucose is fine, her calcium fine. Her WBC is a little elevated. What's causing that? And as soon as we see that, we go down and we look at the differential. Is the differential showing us anything? The granulocytes are elevated and the lymphocytes are low. So that tells us what? Maybe a bacterial infection. Can certainly tell us that. Her RBCs are low, and as soon as we see her RBCs, we look at her hemoglobin and her hematocrit. They're both low, and then that tells us it could be anemia or bleeding, right? So we're going to go to the red blood cell indices first. We haven't seen any bleeding, so we know she's not just hemorrhaging out onto the floor. So let's look at the red blood cell indices. Her MCV is 71, that's a little low. Her MCH is 22, that's a little low. What does that tell us? A microcytic anemia, which one? What's the microcytic anemia we think she has? Iron deficiency. Iron deficiency anemia. What's the number one cause of iron deficiency anemia in adults? I'm sorry, alcoholism, no. I've already said this more than once to you this semester. Not malnutrition. Chronic blood loss, not acute blood loss. Chronic blood loss is the number one reason for iron deficiency anemia in adults. In children, it is the malnutrition, or the decreased iron in their diet. But in adults, it is chronic blood loss. Okay, so then we go through, we see her platelet counts okay. We've already talked about her differential. Which finding is the most serious? The hemoglobin hematocrit. But we looked at that in regards to her red blood cell indices, probably not as serious as it might be, right? Because of that. Anything else that you think is most concerning in these labs? The bacterial infection, yeah. But why does she have an elevated WBC? She could have been on steroids. She's got multiple sclerosis. She could be on steroids. She's not. She's not on corticosteroids. But she could have been. So that is something to look at. Would you call a physician immediately about these labs? Yes, which one? The H&H? And when you did call it, which physician would you call about? Or would you call it to? I'm sorry? The one that ordered the labs, that's exactly right. The ones that ordered the labs. Which was one, do you remember? It was the surgeon, yeah. Okay. If you do call, what orders are you expecting from that doctor? I'm sorry?
Some type of antibiotic.
A type of antibiotic?
Culture.
Blood cultures? Okay. What do you think causes patient symptoms at this point, after you've learned all of this about her? I'm sorry? I can't hear you back here. Anxiety? That's what the dogs thought, wasn't it? How many of you think it was anxiety? How many agreed with the doctors? One? Only one of you? The rest of you, what do you think caused her problems? She did what? They need something, you think bleeding? Chronic bleeding causes iron deficiency anemia, not acute. Well, most likely not a NIC. Anything else? Maybe a GI obstruction. How many of you think it might be a GI obstruction she's experiencing? There's one back there. A couple others. What other interventions would you implement based on the data that you presented, that was presented to you? What other things would you do for her? I'm sorry? No, you wouldn't do that because you're not a doctor. You can request a scan. What nursing interventions would we do? Fluids, we would encourage her to drink fluids. Raise the head of her bed because she's saying she's vomiting. We think there might be something there causing that. Anything else? She can't ambulate. She's wheelchair bound. Yeah, she's got slow down sounds. So she's got slow down sounds and she's in a wheelchair. Guys, think about what would you really do for this woman? She's got slow bowel sounds. She's wheelchair bound. She's told you she's vomiting small amounts. You haven't seen emesis, although you've told her to save it. You've got this order for this Reglan. You've got orders for Xanax. You've got orders for Phenergan. These are the orders that you have. You've got an order for nicotine patch because you called and asked for one. And so you got that. What interventions are you going to do for this woman? Raise the head of the bed, is that it? Later towards the end of the day shift, this patient vomited, aspirated, and died. She vomited, aspirated, and died. She was 50-something years old, 52 years old. She was most likely swallowing the small amounts of vomitus that she had. When she died, she had a husband and a teenage daughter that she left behind. The nurses and the doctors prematurely jumped to conclusions about her condition and overall disregarded the abnormal data. You know, what were they focusing on? Her anxiety. She probably said something to that psychiatrist about being fearful going home, and that just started the ball rolling. Everybody who came in after that point dealt with that hysteria, as one of the doctors called it. She was not hysterically crying, carrying out, nothing like that. He meant hysteria in the sense of fear, is what he meant in that note. But that's all the nurses and the doctors could see. Now, the surgeon did find the sluggish bowel sounds and did order the drug that might have reversed those because she couldn't get up and move around and do it for herself. So he ordered the one drug that might have helped with that. However, it was never administered because it never came from the pharmacy. So the nurses never gave it in the 12-hour shift that they were there with this woman. They totally ignored her progressive vomiting, her progressive nausea, her reports of vomiting. They totally ignored those signs and symptoms in favor of she's anxious. But in fact, never gave her the Xanax, never gave her the Phenergan, never gave her the Reglan, and never put an nicotine patch on her. I didn't do any of those things. But you guys weren't going to do it either. Y'all were just like, I don't know what's wrong, so I'm just going to go through my day in many of your cases and not make any decisions. This is what happens when you don't make decisions or when you make bad ones. This is what happens. Patients get harmed and patients die over this. How do I know this case? I was working as house supervisor, not when this patient was here on this shift. I was not working. This happened during the week and I only work weekends. But when I came to the unit, the next weekend that I worked, the nurses had copied off all of the patient's records and gave them to me because they wanted me to use this as an example for the rest of my students to learn what happens when we do poor nursing care. And I have used it ever since. I've had this for many years, and I have used this ever since because I don't want this patient's life to end and that death not mean something when the nurses did this. This is what bad nursing care can do. Now, the doctors helped, didn't they? They helped kill her. That's usually what we do. If we're going to make a big mistake, we try to get as many people in on it as possible. So that we're all making mistakes together. That's very common. In this case, the doctors led the nurse down the path of the wrong diagnosis. In many cases, it's the other way around. The nurses lead the doctor. In this case, the doctors led the nurses, and the nurses just followed around. Now, I want you to reflect back on this case. How could this have been prevented? From start of this case, from the very first slide, let me go back to the very first slide. I want you to tell me how this could have been prevented. From that slide. Following up on her severe nausea, assessing related to that. They screwed up with assessment. They did not do a good assessment of this patient from the first moment they walked in this room on this shift. They asked her this information, and they got this information. She told them she was nauseated. They did not stop and say to themselves, I must really do a good GI assessment, and I need to do a good assessment of her pain, and maybe a neuro assessment related to that pain. The very first thing y'all said y'all would do, they did not do. They did not do. Because had they done that, they would have realized she had sluggish bowel sounds. They did not realize that from the first. They did not know about the sluggish bowel sounds until the doctor ordered the Reglan. And frankly, they didn't even know about it then because they hadn't read the chart at that point. They just knew he ordered Reglan. So they did not know about the sluggish bowel sounds because they did not do a good assessment of her bowel sounds. They did an assessment of her bowel sounds. They did not pick up that they were sluggish. But they were. And so missing that key point, had they also done a good assessment of her headache, they probably would have seen some differences between this headache and what she has as a migraine, but they didn't do a good assessment of it. So they never found that out. So that was certainly where they made their first mistake. Had they done that well, they would have then gotten to the point here. Now her headache is getting worse. Surely they would have at least attempted to reduce that headache. But also, she's vomiting small amounts. They asked her to save it as the shift went on. She did not save her emesis. They never addressed that. They never asked her, if you're vomiting, where is the emesis? Are you getting up to the bathroom in your wheelchair? How much are you vomiting? What does it look like? They didn't do any of that assessment. They just told her to save it. Every time they went to the room, there was no emesis for them to see, so they thought she was making it up. Most likely, she was refluxing and vomiting it back down, or swallowing it back down. So those were the key points where they screwed up this case and cost this person their life. So what's the take-home message with this?
Assessment.
Assessment, but not just assessment. What else?
Early.
You have to now take that assessment data and do something with it. You have to start putting things together and saying, does this make sense? And if it doesn't make sense, delving deeper into it. With that Reglan, when you're in that hospital, it doesn't come back to you from the pharmacy, it never comes to you. You've got to realize it's ordered, you've got to still give it. It's given for a reason. And so you've got to delve into that. What is it going to take for me to be able to take care of this patient? Remember the question about the interventions. What interventions should you have done for this patient? What should have happened for this patient is, you're right, the head of the bed should have come up. IV access should have been obtained because you're going to need it to give the Reglan anyway. They should have gotten the Reglan from the pharmacy. They should have given her the Phenergan long before the Reglan was even ordered to see if that was going to help her nausea. They should have known about her bowel sounds and put her on a close observation to see if those bowel sounds were going to improve, right? To see what's happening over time. They should have looked at that. When they got those lab values back and they saw that hemoglobin hematocrit was low, they should have been concerned about her saturation, her oxygen levels. They probably should have put some oxygen on her at that point. They should have reported that. They should have reported that WBC. Perhaps she's developed an infection. Maybe this is peritonitis that's going on. In this day and time, with those symptoms, they would have started to look for sepsis, and that day they would not have. But they would have started to look for sepsis, make sure she was not septic. Most likely she had a bowel obstruction, and that bowel obstruction ruptured. What most likely killed her. Well, what killed her was aspirating, but she was probably developing a bowel obstruction that caused her to vomit when she aspirated. But what did kill her was aspiration. Poor nursing care. You don't want to be that nurse, although I suspect that some of you are quite comfortable being that. In the hospital, when they ordered that Reglan, are you grabbing your Lockhart book? Or are you asking the nurse? Which one are you doing? Now, the next time y'all are here, I want you all to bring your Lockhart book. That'll tell me a lot. It'll tell me who actually has a Lockhart book to grab. So you will get classroom credit if you bring a Lockhart book next time. Brand new Lockhart book. That book is invaluable to you. That book is invaluable. Do not rely on a nurse to tell you, because that nurse that you're in that clinical with might be the nurse that killed this patient, or might be the person that was in this classroom last semester and didn't have a Lockhart book. I can promise you that happens. Y'all are perpetuating this bad care because you're relying on the more experienced nurse in your facilities to teach you nursing. And I'm seeing some of that nursing that they're teaching you, and it is scary. So I want y'all to start doing what's right. So next on Wednesday, if you want your classroom credit points, you'll bring a Lockhart book. And we're going to start using that Lockhart book. Any questions about this case?